Welcome back to Neurovascular Nuggets, everyone. I'm Prof. Mansoor, and with me, as always, is the brilliant Salma. Today, we're diving into a really thought-provoking study, number 13 in our series, that honestly challenges some of our long-held beliefs about endovascular therapy in large ischemic strokes. It's about how good enough might actually be good enough, or even better in some contexts.
Thanks, Prof. Mansoor. I'm really excited about this one. It feels like it could genuinely shift practice for a lot of interventionalists. We always talk about time is brain, but this study brings risk of procedure into an even sharper focus, especially when we're chasing that perfect angiographic result.
Exactly. So for our listeners who might not be deep into neurovascular jargon, let's quickly explain. We're talking about endovascular therapy, or EVT, for acute ischemic stroke. And after we've gone in and retrieved the clot, we assess how well we've restored blood flow. This is where the modified thrombolysis in cerebral infarction, or MTICI score, comes in.
Right, we've got MTICI 0, which is no reperfusion at all, up to MTICI 3, which is complete reperfusion. And traditionally, the holy grail has always been MTICI 3, right? Get that vessel completely open, restore full flow to the affected brain tissue.
Precisely. But there's also MTICI 2B, which is often described as near complete reperfusion. It means there's some good antegrade flow, but it's not quite perfect. Maybe there's still a slight delay in distal filling or some small areas of reduced perfusion. For a long time, the thinking was, if you're at 2B, why not push for 3? But this study, a retrospective comparison, actually looked at outcomes in patients who achieved 2B versus those who achieved 3.
And it focused specifically on patients with large ischemic strokes in the anterior circulation and with pretty low baseline aspect scores, 3 to 5. That's a crucial detail, isn't it? These are patients with substantial initial damage, so every nuance of treatment matters even more.
Absolutely, Salma. A low aspect score indicates a larger area of established infarction at baseline, meaning these are generally tougher cases with a higher risk of adverse outcomes. So what did they find when comparing MTICI 2B to MTICI 3 in these challenging patients? This is where it gets really interesting. They looked at 90-day functional outcomes using the modified Rankin scale, which is our gold standard for assessing post-stroke disability.
And the big headline, the main takeaway, was that there was no significant difference in those 90-day functional outcomes. Think about that for a second. We're talking about patients with severe strokes, and whether they got near complete or complete reperfusion, their overall disability levels 3 months later were essentially the same. That's pretty wild, isn't it?
It is, Salma. It really makes you pause and consider. For years, we've been taught, and rightly so, that more reperfusion is always better. But this data suggests that in these specific, high-risk patients, pushing from 2B to 3 might not translate into a tangible functional benefit for the patient down the line. They also looked at other critical outcomes, like 90-day mortality and the rates of independent ambulation, meaning patients who could walk on their own.
And those were similar too, right? No significant difference in how many patients survived or how many regained their ability to walk independently, regardless of whether they hit 2B or 3. This really strengthens the argument that 2B might be an acceptable endpoint. But there was one area where there was a significant difference, and it's a critical one: symptomatic intracranial hemorrhage.
Ah, yes, the SICH rates. This is a very important point that needs careful interpretation. The study found that SICH rates were actually lower in the MTICI 3 group compared to the MTICI 2B group. Specifically, 4.5% for MTICI 3 versus 12.6% for MTICI 2B. This might seem like a counter-argument to stopping at 2B, right?
It does on the surface. When I first read that, I thought, wait a minute, if 3 has lower bleeding risk, why wouldn't we always aim for it? But then I started thinking about the context of the overall findings. If functional outcomes, mortality, and ambulation are all similar, despite a higher SICH rate in the 2B group, what does that really tell us?
That's exactly the nuanced discussion we need to have. It implies that while a perfect MTICI 3 might inherently lead to a slightly lower rate of SICH compared to 2B, the act of getting there, the additional maneuvers, the prolonged procedure time, the increased manipulation of delicate vessels, might introduce other procedural risks that, in the bigger picture, balance out or even outweigh the benefit of that reduced SICH. We're always trying to strike that delicate balance, aren't we?
Absolutely. It's not just about one outcome, it's a holistic view of patient benefit versus potential harm. If you've got a good, robust MTICI 2B and you're contemplating another pass, another stent retriever deployment, another aspiration, each of those carries its own set of risks. You could have vessel dissection, distal embolization, even just a prolonged exposure to contrast or radiation. So the benefit of theoretically lowering SICH might be offset by increasing other complications or just simply wasting precious time without improving the ultimate functional recovery.
Precisely, and the study further bolstered this by conducting subgroup analyses. They looked at whether factors like patient age, sex, or even baseline stroke severity made a difference. And the result? MTICI3 reperfusion didn't provide any added benefit over MTICI2B regardless of these patient characteristics. This really strengthens the generalizability of their findings within this patient population.
So the implication here is pretty significant then. It's basically telling us that MTICI2B might indeed be an acceptable angiographic endpoint for EVT, especially in these large anterior circulation strokes with significant baseline infarct. It questions whether we need to keep chasing that perfect MTICI3 result with additional maneuvers.
That's the core message, Salma, and this leads us directly into the clinical implications. For interventionalists, this study strongly suggests that we need to carefully weigh the risks and benefits of pursuing MTICI3 if we've already achieved a good MTICI2B early in the procedure. It's not a blanket recommendation to stop at 2B every time, but it certainly provides a strong argument for considering it.
It's about individualized decision making, isn't it? Knowing that MTICI2B might yield comparable functional outcomes to 3, we can potentially reduce overall procedural risks by not over-manipulating the vessel, even if it means a slightly higher theoretical SICH rate compared to a perfectly achieved MTICI3. The overall patient benefit comes from minimizing total complications and ensuring the best functional recovery, which this study says is similar for 2B and 3.
Exactly, and a very practical point raised is the idea of intraprocedurally evaluating the extent of persisting hypoperfusion versus established infarct on imaging. This could really help guide whether to continue manipulating beyond MTICI2B. If you've got good perfusion to a significant portion of the salvageable tissue and the remaining hypoperfusion is in an area that's likely already infarcted, then pushing for MTICI3 might just be chasing an angiographic ideal without a real clinical benefit.
That's a fantastic point, Prof. Mansoor. Using adjunct imaging, perhaps an on-table C-arm CT with perfusion, could really inform that decision in real time. It moves us away from a purely angiographic endpoint to a more physiologically driven one. It's not just about opening the vessel, it's about what part of the brain is still alive and can benefit.
Precisely. The results from this study will undoubtedly help guide individualized decision-making on optimal angiographic targets during EVT for these specific types of large strokes. It's a step towards more personalized medicine in stroke intervention, which is always our goal. But, as with all good research, they rightly conclude that more data is needed to develop definitive recommendations. This is a single retrospective study, so prospective trials would be invaluable.
Of course, one study doesn't change everything overnight, but it definitely opens up a very important conversation. It makes us question our assumptions and critically evaluate our procedural goals, especially in cases where we're really struggling to get to a perfect MTICI3 and every extra minute and extra pass feels like we're just adding risk. This study gives us some data to support a less aggressive approach in certain scenarios.
Indeed, it's a very practical and clinically relevant nugget. The take-home message, to reiterate, is that this study questions the clinical benefit of mandating MTICI3 reperfusion in EVT for large anterior circulation strokes. It really supports the idea that, in some patients, stopping at MTICI2B could be the right call to limit overall procedural risks without compromising the ultimate functional recovery.
It's a powerful reminder that sometimes the pursuit of perfection can be the enemy of good, especially when patient safety and long-term outcomes are at stake. A good MTICI2B achieved quickly and with minimal manipulation could very well be the optimal strategy for many of these patients.
I couldn't agree more, Salma. It's a fantastic discussion point for stroke teams everywhere. We need to internalize these findings and integrate them into our decision-making algorithms, always keeping the individual patient's risk profile and benefit in mind. Thank you, Salma, for breaking this down with me today.
Thank you, Prof. Mansoor. It's always a pleasure to discuss these crucial insights. And thank you to all our listeners for tuning into another neurovascular nugget. We hope this episode sparked some valuable thought and discussion in your practice.
Absolutely. For more details on this study, you can find the link in the description and search for #neurovascularnuggets. We'll catch you next time for more essential insights in neurovascular care. Stay safe, everyone.